Hi, everyone. Welcome to MSART's 12th webinar today. It's co-organized by Alpha IVF Women Specialist Center in collaboration with Alhaya Fertility Center in KL. Well, I'm Dr. Pandian from Penang. I will be your moderator today for the webinar. Before we get started with today's session, I'm excited to announce some updates about our upcoming MSART in 2024 conference this October. This year, we are embracing the theme, looking within to grow beyond, right? Which centers the transformative changes, whether major or minor, that have the potential to profoundly elevate our everyday practices. The MSART 2024 conference will take place on the 5th and 6th of October at Sunway Pyramid Convention Center. We have assembled an impressive roster of both local and international speakers, each presenting on a range of compelling topics. Our keynote speaker will be Prof. Dr. Kazuhiro Kawamura, all right? The Professor of Obstetrics and Gynecology at Juntendo University of Faculty of Medicine in Japan. He will deliver a fascinating lecture titled In Vitro Activation, Current Trends and the Future. For more information on our speakers, please visit our website, all right? So this conference offers a fantastic chance to broaden your knowledge and build meaningful connections within our industry and fraternity. Registration is now open and you can sign up today and join us there, right? Okay, next, let's go to our next webinar, all right? It is scheduled on August 29, 2024. Prof. Christopher Blockhill, Professor and Medical Director at the Center of Reproductive Medicine from Brussels, Belgium, will present on optimizing success in ART. World insights on treatment and personalization with HMG. Registration for this session will open shortly, all right? Okay, now let's turn our attention to our today's webinar. We are delighted to welcome Dr. Syahirah Yang Mohsin, consultant obstetrician and gynecologist and fertility specialist at Alpha IVF and Women's Specialist, as well as Alhaya Fertility Center. All right. She was my houseman when I was doing masters in UKM, and I have seen her growth over the years from a dedicated house officer to a dedicated medical officer and registrar, and currently she's a subspecialist in fertility. Fantastic growth, Syahirah. And Dr. Syahirah will be talking about reviving hope in vitro activation. All right. As Dr. Syahirah will share her expertise, please feel to submit your questions in a Q&A box, and we'll address them during the Q&A session and end of the presentation. All right. Syahirah, are you ready? All right. So before we go on, I will also slightly tell about Syahirah. Syahirah has obtained her fellowship in reproductive medicine from several notable institutions locally under MOH and in abroad, including gynecology, endocrinology, and reproductive medicine clinic at Medical University Innsbruck, Austria. Since 2018, she was also the research fellow focusing on immunology and clinical study of current implantation failure and recurrent miscarriages, endometriosis, and adenomyosis. And currently, Syahirah is one of the leading fertility specialists in Alpha Fertility Center as well as Alhaya Fertility Center in KL. Syahirah, it's all yours. Okay. Just hang on, guys. I think probably there's some technical errors here. Okay. So while waiting for Syahirah, let's talk about our MSART conference, which is will be held in Sunway Pyramid Convention Center in October, October 5th and 6th. So the registration has been open, and probably all of you can start registering. And those who are not MSART member yet, yeah, you're welcome to join as our members and enjoy the privileges and let's hope to see all of you there. And probably we have all the, as I told you, we have very good topics by our local speakers as well as our international speakers. Probably it will be a very good opportunity for all our fellow medical officers and registrars who are interested in fertility, as well as our junior fertility specialists, as well as for all of us to gain and improve our knowledge in fertility as we move on. All right.
Hello, hi everyone.
Yeah, welcome,
Sorry
Syahirah.
for the technical problem. Sorry for the technical problems at
No
depannya.
worry, it's all yours.
All right. Okay, let me share my slide. Okay, so I'm Dr. Sarah, right? So today I'm going to share with everyone regarding a topic, reviving hope in vitro activations. So I believe this is considered a new knowledge for not only for me, for everyone of us, all right? So yeah, so in our practice in ONG, definitely we have encountered managing patients with premature ovarian insufficiency or even diminished ovarian reserve. All right. So in current era, as we all know, there is increasing in women, advanced age women who come to seek for fertility treatment. Not only that, we have more and more cancer survivor that come for fertility treatment. All right. Probably because advancement in the cancer treatments. So we have more and more cancer survivors at reproductive age group, and this group of patients tend at risk of having premature ovarian insufficiency. So what is the option for them? Is adoption the only option, especially for Muslim couple where egg donation is prohibited? Okay, so IVA started in Japan around 2010 due to increasing in the incidence of premature ovarian insufficiency as well as diminished ovarian reserve. So egg donations is actually illegal and not allowed in Japan. And considering this increment in the incidence of poor ovarian reserve patients, research scientists led by Professor Kazuhiro Kawamura has started this new technology called in vitro activations with the aim to reactivate the ovarian follicle remnants as early as primordial follicles, primary follicles, secondary follicle, and pre-antral follicles, hoping to improve the chances of this group of patients to improve their reproductive potential. Okay, and in 2013, actually first case of successful live birth in Japan have been reported in the world from grafting vitrified ovarian tissue followed by IVF in patients with premature ovarian insufficiency. All right, so as you can see, this is Professor Kazuhiro Kawamura. So he had transferred a fresh day 2 embryo, which eventually leading to a successful delivery of this cute baby. Okay, so we are grateful that Professor Kazuhiro and his team came to Malaysia the first time for the first 6 cases of IVA surgery in Alpha IVF Kuala Lumpur in February. And we had operated around 6 cases of IVA, which include diminished ovarian reserve cases, as well as premature ovarian insufficiency cases. All right, so let's understand the fundamental of IVA. So IVA is a technology where we aim to reactivate early follicles, which include primordial follicles, primary follicle, secondary follicle, to pre-antral follicles. All right, so this is our target. Okay, at this point, is FSH dependent, where the patients will be then scheduled for IVF stimulations. Okay, so what is IVA? So when they first started doing IVA in 2010, the intention was for fertility preservations, especially in cancer patients. as they are suffering from premature ovarian insufficiency. So when they first started doing IVA, it was more invasive as it requires 2 surgeries, all right? And one of the ovary will be removed, okay? And portion of the ovarian tissue will then be fragmented and cultured with the IVA drug activator. Otherwise, the remaining ovarian tissue will then be cryopreserved for future use. So for cancer patients who had completed their cancer treatment or remain or disease-free, the fragmented tissue will then be transferred back for their fertility, as well as for patients with POI, okay, after fragmentations and IVA drug treatment for about 48 hours incubations, the tissue will then be transferred back into woman pelvis and subsequently will proceed with IVF treatment. Okay, so this is the activator that was used in the original IVA, where they use P13K stimulator and P10 inhibitor. So if you look at this diagram, it's going to be quite complex, okay? Don't worry, you don't have to remember all this. Most importantly, all this molecular process will eventually lead to activations of primordial follicle. Okay, so animal studies has been conducted by Kawamura et al. In 2013 among ovarian in mice ovaries, which has proven there is increment in the early follicle antral follicles as well, which include secondary follicles. Okay, not only that, other studies also has been conducted where they want to investigate whether in diminished ovarian reserve or early POI patient, is it possible to just stimulate the residual follicles, all right, to increase number of antral follicles by tissue fragmentations and mechanical manipulations, hoping to activate the hyposignaling pathway. So it has been proven that this process of tissue fragmentation can actually activate this pathway, which eventually lead to increment in the follicle growth. So clinical studies also has been conducted in 2016 among premature ovarian insufficiency patients, where up to 6, all right, 6 of the patients from 14, 6 out of 14 patients actually showed. So this patient group of patients of POI that has gone through IVA surgery eventually proceeded with IVF stimulation. They found that 6 of 14 patients actually had follicle development. All right, and then not only that, when they investigate further in terms of the AMH level, there's also increment in the AMH level, especially in the first 200 days after IVA surgeries. So as you can see here, this diagram, it showed clearly that follicle growth patterns among patients varies, okay? Because it depends on the patient's response, patient's profile, which is different, okay? So the one in pink shows spontaneous follicle growth, which is as early as within 1 month after IVA surgery, right? The one in red is hormonal stimulations, which is IVF stimulations, which clearly shown here, minimum of within 1 month or even maximum up to 10 months. So meaning the response of follicle growth varies between patients. It depends on the complexity of the problem. So evolutions of IVA, when they first started doing IVA, it was conventional IVA as being summarized here, all right, which is more invasive as it requires 2 surgeries, 2 days of incubation with activator. And they have moved to drug-free IVA, which is less invasive. It's only 1 surgery where only portion of the ovarian tissue cortex will be removed, rather than the whole ovary in conventional IVA. And then in drug-free IVA, there's no activator needed, only fragmentation of tissue, which then grafting back. So the evidence has showed comparable outcome, okay? So as you can see, this diagram clearly explains 2 surgeries in conventional IVA and the drug-free IVA. All right, so based on the current clinical outcome in drug-free IVA, okay, which has been published in 2019, it has been reported that 9 out of 11 poor ovarian response patients with diminished ovarian reserve actually has increased in the anterior follicle count in multiple growth waves following IVF FSH treatment. And not only that, there is also increment in the mature oocyte after ECG trigger with median AFC before and after IVF per ovarian stimulation of 1 versus 2.6. And there is also increment in the fertilization rates up to 68.7%, higher chance of having high quality embryo, and successful pregnancy was actually achieved in 4 out of 11 patients, which is about 36.3%. So even though it seems that it's small in percentage, but it's still some outcome rather than nothing, right? Okay, so based on the studies, successful pregnancies in 4 out of 11 who actually failed pregnancy by more than 2 previous IVF cycles. And 3 patients who have cryopreserved embryo were actually waiting for embryo transfer at the time of the publications. So another studies also have comparable outcome, which was around 13 out of 15 patients among those with diminished ovarian reserve and premature ovarian insufficiency also have comparable outcome of increase in anterior follicle count, increased number of retrieved oocyte, spontaneous pregnancy, and also live birth and ongoing pregnancy. Okay, so in 2022, okay, they have moved to a new IVA, all right, new IVA applications with the hope to further improve the outcome of patients going for IVA treatments. Okay, even though we are all aware that tissue fragmentation only is good enough for patients with diminished ovarian reserve or even those with early POI, but still there are a group of patients, especially those in established POI patients, that probably require more therapy. And that's the reasons from these new IVA applications, we add more potent reagent to reactivate the dormant follicles. Okay, so again, it's almost similar concept. It's one surgery where a portion of the ovarian tissue cortex will be removed and fragmented. And then there will be reagent X, factor X that been added as an activator, which is actually a growth factor. All right. And after about 30 minutes of culture, it will then be transplanted back into woman pelvis. I will show in videos after this. Okay, not only that, we also add on PRP, which is actually a growth factors that potentially beneficial to improve the number of follicles and possibly the quality of the follicles that being produced. Okay, so here I would like to share with every one of you the IVA surgery that was conducted in Alpha IVF Kuala Lumpur. All right, so first step, okay, we're gonna cut the ovarian tissue cortex, okay, about 1 times 1 centimeter, which is 10 millimeter times 10 millimeter incisions over the ovarian tissue cortex using a micro dissecting scissor of 5 millimeter. So with this type of scissor, we'll be able to remove the cortical layer of the ovary more accurately and avoid cutting into the medulla. And after that, the tissue will be then be cut, okay, and given to the laboratory. Okay. And then it will be placed in the dish with culture, with buffer media together with the factor X, which is actually a growth factor. At the same time, it will be fragmented into small pieces as small as 1 times 1 times 1 millimeter power of 3. Okay, so at the same time, it will be cultured for up to 30 minutes. And eventually, it will be placed into IVA cannula, all right? So maybe you can see here. So this is the process of tissue cutting. Okay, and eventually it will be placed in this IVA cannula. Okay, in total, it is recommended to get around 30 to 40 pieces of fragmented ovarian tissue, which will be placed in the cannula. Okay, after that, okay, while waiting for the culture of up to 30 minutes, most of the time we will proceed with the PRP injection on both ovary, both right and left, okay, of the cortical layer, of the cortex layer of the ovarian tissue. And then after 30 minutes, we can transfer the tissue, but of course, before that, we need to create a space, okay, and like a pouch in between the cortex and the medulla layer, all right, around 1 centimeter pouch, in order for us to place the cannula, all right, through the pouch, and the fragmented ovarian tissue will be then transferred here. Okay, so what is the indication for IVA? IVA is indicated for patients not only for premature ovarian insufficiency cases, it's also for diminished ovarian reserve patients. So is it for everyone with diminished ovarian reserve? So it is recommended in advanced age women, all right, especially when they had previous poor ovarian response, those who had less than 3 oocytes with a conventional stimulation protocol, or maybe they had poor IVF outcome from previous IVF stimulations, okay? And predictive factors for the presence of residual follicles. So when we have cases which indicated for IVA, we can some sort of predict in terms of the chances of success. Okay, if the age onset of amenorrhea is less than 40, the chance of success is higher as compared to those after 40 years old. And the onset of amenorrhea is also important. If it is less than 4 years old, the chances will be better. And the last one is the ovary size, especially at the time of surgery. We will, before surgery, definitely we need to assess the ovarian size, and intraoperatively, all right, we will further confirm those bigger size or those with more follicles seen even before surgery will be chosen as the site of surgery for IVA. Okay, so generally management approach for IVA, it starts from pre-IVA surgery, the preparations, which most importantly that we need to do is counseling. Couple counseling is really important because we need to make them understand the process of IVA, all right? It's a long process that they really need to commit and comply to the treatment, okay? No, we have to optimize their hormonal profile. We need to take their hormonal profile, which include FSH, LH, E2 level. Okay, once the E2 level reach the target level of 50 to 100 kg per mil, then we can proceed with IVA surgery. Okay, and after that, we're gonna induce their period by adding on progesterone and then start the IVF stimulations with FSH only. Okay, 4 to 7 days of monitoring. So the IVF stimulations after IVA is slightly different than conventional IVF. Reason being because the follicles that we're gonna stimulate now they are early follicles. Okay, they come from primordial follicles. So the approach is slightly different. So the monitoring is about 4 to 7 days monitoring, depends on the follicle size, depends on the hormonal level. Okay, and most of the time they require higher HCG trigger due to poor vasculature at the grafting site. And the approach is to trigger when the follicle reach around 14 to 18 as compared to standard IVF, which we wait until 18 millimeter. But in IVA, based on the recommendation is to trigger earlier, okay? So it has happened to one of my patients previously that I triggered much later, okay? What happened is that the eggs actually become degenerated after upon injection after ICSI. Okay, so meaning it clearly showed here the follicles is probably more fragile as it comes from primordial follicles. So at the same time, we do consider dual stimulation, especially in cases where there is residual follicles less than 8 millimeter. Okay, so I would like to share two IVA cases that has gone IVF stimulations in our center, right? One of the case is POI case, which is 37 years old lady, 8 years infertility, with irregular menses, okay, no medical problems. So uterus normal size, but the ovary the size seems to be smaller than the usual size. And we couldn't see any follicles by ultrasound. All right, so investigations also revealed bilateral tubal blockage by HSG, and hormonal profile FSH was raised 60.7, LH 29.2 with low E2 of less than 18 pico per mole, AMH of less than 0.07 pico per mole. Prolactin and thyroid function were normal. Karyotyping was 46XX, and husband sperm revealed teratospermia. So IVA surgery was done in February, where at the time of surgery, both ovarian size is actually almost the same size, but generally smaller than the normal size. So IVA was done on the right side. At the same time, PRP injection were done on both right and left. So AMH actually pre-IVA was less than it was 0.07. But after IVA, AMH actually raised to 0.1 picomole per liter. So eventually, once the patient had periods after IVA, we started the IVF stimulation. Unfortunately, after up to almost 28 days of stimulations, the cycle was then abandoned as no follicle seen. But then I think patient probably demotivated. Patients didn't turn up until recently. Patient come back for another IVF stimulations. And good to know that based on the most recent scan done on day 2 menses, she was found to have the first antral follicle seen. Okay, so even though it's only one, but still at least we can see something rather than nothing. Okay, so let's pray that she's gonna have a good outcome soon. Okay, so next case is a case of diminished ovarian reserve. All right, patient is a 44 years old lady, married for 2 years. Normal uterine size, the ovary right and left also normal size. So on the right side, I could see around 2 antral follicle count. On the left side, on 1. AMH less than 0.7 picomole. Otherwise, sperm analysis was normal. So she had a conventional IVF cycle before with pergoveries, total up to 12 days of stimulations. She only had 2 follicles, which size dominant follicle at the time of OPU. Unfortunately, only 1 M2, but it was poor quality eggs that degenerated after ICSI. And subsequently, she was counseled for options of ovarian PRP to further optimize her outcome. All right, so after PRP, break of 1 month, and the second month after over PRP, we started the IVF cycle. Despite again 12 days of injections, IVF stimulations, there's no follicle response, right? Despite having 2 follicles, it remains small despite 12 days of stimulation. Hence, again, the cycle was abandoned. So subsequently, patients was counseled options of IVA, considering her poor IVF outcome. So which was done in May, about 3 months ago. So intraoperatively, right ovary was found to be larger than the left one. Hence, right IVA was done, and bilateral ovarian PRP injections are also done. So AMH was found to be increased. Before IVA was less than 0.7. After IVA surgery, the AMH increased to 2.1 picomole per liter. Okay, so subsequently, we did IVF, okay, in June recently. So stimulations of 375 up to, which further increased up to 450 IU. So if you all realize the dose of FSH being used in IVA is higher than the conventional IVF, reason being again because of the poor vasculature of the ovarian tissue grafting. They require higher FSH injection in order for the follicle to grow. So 3 follicles were dominant follicles, 2 from the right and 1 from the left. 2 from the right, the side of IVA side, and 1 from the left. So OPU was done on day 15, and we had retrieved 2 M2 eggs. Okay. And at that time, she had 1 embryo frozen good quality. Okay, so at this point, day 3 embryo was frozen, considering a very precious eggs that she had. So day 3 embryo was frozen. So subsequently in July 2024, she had a natural cycle IVF, one dominant follicle. We did OPU on day 15. Unfortunately, there was no eggs. And in view of she had residual follicles, which was less than 8 millimeter, I continued her luteal phase stimulation where she had one dominant follicle at the size of 16 millimeter. I proceed with a trigger and OPU then noted 1M2. And again, she had another one embryo frozen, good quality, day 3. So now she has two day 3 embryo frozen, okay, which is around 8 cell grade 1. So now patient is planning to go for another IVF stimulations, all right? So hopefully we can get more eggs for her case, and we'll be able to culture up to blastocyst, all right? So with this new IVA method, it is still under ongoing research, all right? And we collaborate the studies together with Japan and India. For us in Malaysia, Alpha IVF Kuala Lumpur, together with my friend Dr. Faiza in HUKM, we are collecting data for all IVA cases that we had operated and undergoing IVF stimulation. So hopefully once we get more information, we can share the outcome to everyone. All right, so here I would like to share probably the treatment challenges for patients who's going for IVA. So first and foremost, of course, we need to handle the psychological as well as the couple expectations. Okay, since everyone is aware of the unpredictable response or even outcome following IVA treatment, and the fact is the cost of the treatment is expensive. Okay, it requires multiple follow-up, okay, and also time consuming, okay, and the outcome of the patients also varies as all the patients have different profile as well as different complexity of cases. So because of that, proper intensive counseling is really important before we proceed with IVA, and proper selections of cases that suitable for IVA also need to be done. And eventually IVA is of course not for everyone, but it's something to be considered in patients with premature ovarian insufficiency, especially where this group, especially in cases where they're really keen to use their own eggs rather than going for donations. Okay, so for diminished ovarian reserve, in cases where they had failed previous conventional stimulations, there's a role of considering IVA treatment too. Okay, so I think with that, I would like to end my presentations. Okay, and if you have any questions, you may proceed with the Q&A. Hello?
Yeah, thank you, Syahirah. Can you hear me now?
Yeah, Dr. Pandian.
It's raining here, so there's some technical issues, I guess.
Okay.
Yeah, thank you. Thanks for the wonderful presentation. Yeah, all right. So let's go to the Q&As, question and answers here. All right. Yeah. What is the maximum age for considering this IVA? Is there any age limit, or as long as they want to do IVF, they can go for it? What do you think?
Okay, so generally 45 and above is considered perimenopausal. So this group of women, definitely they have a problem of diminished ovarian reserve. Not only that, the issue of egg quality, especially related to chromosome defect, which up to now, we don't have any, there's no treatment that will be able to reverse this chromosome defect. So in this group of patients above 45 who keen to proceed with IVA, yes, there's a role of doing, but of course, we need to counsel the patients, the outcome might be really challenging.
Yeah,
Okay,
I guess that.
especially those above 45. So we should discuss it in advance, all right? But of course, in selected cases, I do have one patient that went through IVA with me. She's 46 years old, but she still got few number of follicles, and she is really passionate to try. So in this group of patient, yes, I may consider doing IVA. Especially they are very keen to use their eggs rather than egg donation. Yeah.
Yeah, I think it gives an option to all
Yes.
those who are not keen for egg donation, and when the religious issue comes in as well. So for those, this is actually it's a very good option actually, Sarah. Okay, of course, talking about IVA, the cost, right? Isn't it? It has to go through a laparoscopic surgery and all that. So how much is roughly it's going to cost, and does of course obviously I think insurance is not going to cover this, right? And
Mm.
apart from the cost, how do you convince the couple to go for this IVA?
Yeah. So how I convince the couples? So usually those couples that come to see me that they're really keen to continue with this IVA, I will explain to them that IVA is not a one-off procedure, meaning it's not just doing surgery. It's
Yeah.
a journey that the couples need to go through. Preparation start even before surgery and after surgery. If they understand that, yes, I will proceed with IVA. Okay. And they need to understand the possible outcome, that it is unpredictable. But of course, there's a role to try if they really keen to try.
Okay. What
Mm.
about the cost? Roughly, how much
The
is it?
cost. The
Hmm.
cost of IVA treatment, IVA surgery, for us in you mean in Alpha IVF KL?
Yeah.
Less than 20,000.
Okay. Right.
Okay, slightly less than 20,000. But in Japan, it costs around 10,000 US dollar.
That's okay.
Yes, it's really expensive.
Hmm.
Mm.
Okay, so in case if somebody wants to come and do in Alpha, is there any discount or anything for the patients?
Discount. That part, of course, will be discussed with the team. All right,
Yeah,
it's not within my control.
understood.
Yeah.
Understood. Okay. So of course, another question here is what is the percentage of success of IVA, meaning clinical pregnancy? I think it's still ongoing, still ongoing. And
Yes.
do you have any data from any other countries that you have any clinical pregnancy rates?
It's still ongoing, especially for current method of IVA, new IVA that we are, I mean, that we are still collecting data. So I cannot quote any percentage of pregnancy, especially the cases that I have operated, the ongoing IVA, they are still collecting embryo. They haven't transferred the embryo. So in our setting, we don't have any rate for now, but based on the available evidence that has been published, one of the paper quoted up to 36% chance of success.
I
Yeah.
see. Okay.
So
That's
available
actually,
evidence is actually, of course, it's limited because of number one, varieties of patients profile. Okay. And currently they have moved to new approach of IVA that is still ongoing research. But
okay.
up to now, for the past 14 years, they have been doing IVA. It was estimated around 100 live births has been reported after IVA. This is
Hmm,
the number that I get from Professor Kazuhiro.
I see.
Yeah.
Okay. Okay. And just now during your presentation, you were saying that you only use FSH, you don't use LH. Is there any reason behind it? And what about the trigger? Do you have any specific drugs for the trigger, or you
Okay.
use our normal routine drugs?
All
Mm.
right. So in order for the follicle to grow, we need to monitor the hormone level, where we need to aim for the FSH level to be minimum 30 and above. Okay, so in order for the follicle to grow, they require a high FSH due to poor vasculature. That's number one. The other thing is we avoid giving LH as we need to avoid premature LH surge. We need to avoid premature LH surge. As we all know, patients with poor ovarian reserve, they're at risk of early follicle ruptures. So we don't want that to happen. That's number one. At the same time, we need to make sure the LH level remain less than 10 throughout the stimulations. Yeah. So that's one of the explanation for that. And the other thing is you asked about HCG trigger, right?
Yes, yes. Trigger. Do you have any?
Yeah, they also require higher dose of HCG trigger, which I give up to 3 vials of recombinant HCG trigger. And I do realize even though the follicles at the time of trigger is only 14 to 18, I managed to get M2 follicles because high HCG trigger will help to improve vasculature, and because of that, it will improve chances of having M2 eggs.
Okay. And you were saying just now that a dual trigger, right? So when you do dual trigger, is there a possibility, or do you use only HCG, or you use HCG as well as DECA?
Or we use HCG. We still
HCG.
use HCG even though it's a dual stimulations in patients with IVA, because we need this HCG for the maturations of the follicles. Yeah. But of course, I do aware that in dual stimulations, the recommendations also to use DECA trigger, right? But in IVA, I have discussed this with Professor Kazuhiro too. The recommendation is still to give HCG trigger.
I see.
For
Okay.
both follicular and luteal phase stimulations.
Okay. Then, so when you do this, do you go for fresh transfer or you go for frozen? So in the event that you're going for frozen, are you going to freeze on day 3 or day 5? And again, would you like to do a PGT on these patients?
Wow. Okay. So, yeah, so the recommendation is always to collect as many eggs as possible through multiple IVF stimulations. Okay. If patients is financially stable, the aim is to collect as many follicles through many IVF cycles, because this group of patients, the effect of IVA lasts for only about a year. All right. So it lasts for about a year. So within this 1 year period of time, we need to maximize their potential to get as many eggs as possible. Okay. Hoping to get as many frozen embryo as possible. The recommendations, although the recommendation is to freeze day 2 to day 3. Okay. Due to embryo that develop from these neo follicles, but it still depends on patients, depends on the clinician's assessment that we need to consider our laboratory setting. Okay, if we have good laboratory, I think there's a role to culture it anti-blastocyst. Okay, provided, okay, patient is well informed of the possible outcome. Okay, at the same time, we have to look into patient's profile. Okay, whether has ever patient had any blastocyst before, maybe, or whether is there any issue with poor egg quality that there's a concern if we culture in anti-blastocyst, then it may not be able to reach blastocyst. So it's a bit gray area here, either to culture up to day 3 or day 5. But of course, there's few information, there's few parameters that we need to consider. As I mentioned just now, the laboratory, of course, the patient's profile. Yeah.
Okay. All right. So let's say you are after the IVA, you are doing the stimulation, and how long do you go about giving the stimulation? Let's say probably after 10 days, you still don't see a follicle. Is there a role to continue? And if there is a role, how long do you go about it? And is there a role for repeated IVF cycles as well as you want to collect the eggs? And in the event if you don't get a proper result, is there a role for repeat IVA?
Okay. For the IVF, you asked about IVF stimulations, right?
Yes,
The first one. Okay. So based on the case that I shared earlier, patients of POI, after up to almost 28 days, there wasn't any response. So the question is when we should put a full stop after stimulations. So I discussed this with Professor Kazuhiro too, whether I should continue the stimulations. So based on the recommendations, it was stated that even based, I read through the articles that have been published, minimum of 3 weeks. Okay, we may consider up to 3 weeks, especially in IVA cases that operated for premature ovarian insufficiency, because premature ovarian insufficiency involve reactivations of early follicles from primordial follicles. Hence, it requires longer time of stimulations. All right, so as published, one of the paper that been published earlier, there were cases where up to 10 months after IVA, then only they started to find this follicle growth after hormonal stimulations. So yeah, I know it's not easy. We need to be able to convince patients, as long as patients stay motivated, okay, we can keep trying within this period of time.
So
Okay,
you,
so
yeah,
yeah.
you mean to say that we can go on stimulating until 21 days?
Yeah,
And
based on the recommendations is up to 3 weeks or maximum up to 4 weeks. And the
wow,
dose of the stimulations, maximum, it can go up to 600.
wow, okay. That's going to cost a lot for 3
Yes.
weeks.
So
So,
that's the reason it's going to be really expensive. And we need to discuss this with patients.
yeah,
Mm.
detailed counseling is needed, right?
Mm.
Okay, right. Mm, okay, do they, I mean, there's another question here. Is there any withdrawal bleeding after post-IVA? So I was wondering, withdrawal bleeding is from the ovary, or is it from the uterus? So they didn't say anything, but I guess it's from the ovary, I guess. Is there any bleeding?
Yeah, after
Ovary.
IVA, okay, we have to add on progesterone for the withdrawal bleeding.
Hmm,
Okay, because before IVA, we will start patient on continuous estrogen stimulations with
hmm,
the aim to maintain the E2 level of 50 to 100 pg per mil. So after IVA, we need to induce withdrawal. So after minimum of 3 weeks of as continuous estrogen, we need to add on progesterone together with but estrogen we shouldn't stop, we should continue. So we add on progesterone for about 7 to 10 days for withdrawal bleed. Okay,
hmm,
but once patient bleed, we should still continue this estrogen just to maintain the baseline level of E2 or 50 to 100. This is important for the follicular genesis
hmm.
in IVA.
Okay, great. Okay, let's say when you do this surgery, I mean, let's say when you retrieving the ovarian tissue, sometimes it may bleed right from the ovarian side. Of course, we are not supposed to use any diatomy. You're going to destroy the ovarian tissue. Is there any how is there any recommendation how to go about it in the event there is a bleeding?
Okay, so usually, if you operate POI patients, most of the time you won't get any bleeding. That's what happened to my patient that I operated earlier. POI case, there wasn't any bleed because of poor vasculature.
I
Okay,
see.
for POI patients. So in diminished ovarian reserve, yes, it tends to bleed maybe because of they have the follicles, all right, especially the secondary follicle is there. It's just that at the time of incision, if we cut too deep until it reach medulla, it may bleed. So that's the reason the first and most importantly, we need to have a good equipment, proper equipment, where the recommendation is to use micro dissecting scissor of 5 millimeter. Then we can delineate the ovarian tissue cortex more accurately and avoid cutting into medulla. That is the point where you're going to have bleeding. So, but in the event of bleeding, we just recommend to apply compression on it. Okay. Do not use any energy devices to stop bleeding. With compression, you'll be able to stop.
Yeah.
Even in my experience, sometimes I add on tranexamic acid, and most of the time it will just stop.
Okay, great.
Yeah.
And after the retrieval of the ovarian tissue, then you culture the tissue, then you put it back again, right? So is
Yeah.
it requires two different surgeries, or in one setting you just do it? Is it, how does
In
it go?
one surgery, the new IVA method, all right, is only one surgery, where through one surgery, we remove portion of the ovarian tissue, okay, about 1 centimeter, and then it will be cut into small pieces and will be placed in the dish with buffered media together with factor X, all right, the growth factors, for 30 minutes.
I see.
Okay, while we are doing the fragmentation, it's going to take up to minimum, I think, 15 minutes, then another 15 minutes, just continue culturing it with the activator, with the growth factors, factor X. And then with IVA applicator, we're going to transfer it back into the pouch in between ovarian tissue cortex and medulla.
All right. Wow, that's great. All right, that's interesting. Okay, this is out of topic. You mentioned that you also give ovarian PRP injections, right? Yeah. So ovarian PRP injection also, it has been increasing when people have started doing it, and it also another option for those can't afford IVA or they are in place where the IVA is not given. So many protocols about this ovarian PRP, whether it to be done once or 3 times, and when is supposed to be done, which cycle of the menstrual cycle. No? So do you have any idea? Do you have any? Would you like to update us anything on this ovarian PRP?
Regarding ovarian PRP, yeah. So, in patient with diminished ovarian reserve, I don't straight away plan for IVA. So that's what happened to the patients that I shared earlier. A case of diminished ovarian reserve, I did over PRP. The recommendation is to do during follicular phase, okay, where we're gonna inject it into the ovarian cortex. So the amount of PRP injected depends on the ovary size. So that's the reason a complete assessment is important. We need to measure the size, and after the injections, usually 2nd month, there will be a break. And the 1st month after ovarian PRP, it will be a break without any stimulation. Only the 2nd month that we start the stimulations. So this is the regime that we have been doing. So I did the same thing to my patients. Unfortunately, the outcome was still not improved, and that's the point where, in view of her age, also it's already advanced or 44, she doesn't want to wait anymore further. And I counsel her the options of IVA, which she's agreed upon. And thank God she managed to get 2 frozen embryo now.
Wonderful, amazing. What is the highest age for this IVA treatment? Anyone beyond 46? Any
Yeah.
data?
Based on the discussion, maximum age that has been done is 47. So that's the reason for our study, we include up to 47 only. Above 47, we are not going to include for the study. But of course, if this group of patients come to see, will you consider, Dr. Pandian?
Probably I need to discuss with you. You are the
Yeah. So those above 47, I will tell them frankly, the outcome is probably is not good as those less than 47. Yeah.
Agree. Well, Syahirah, thank you so much for your wonderful presentation and very insightful as well. And thank you very much for the question and answers as well. Wonderfully answered. All right. And we also extend our special appreciation to Alpha IVF as well as Alhaya for their as being a co-organizer. Okay. So thank you everyone, and Syahirah, thank you again once again. Yeah, thank you very much for the wonderful presentation. Yeah. All right.
Thank you, Dr. Pandian.
Yeah. All right. So for those who have joined today, thank you very much for spending your wonderful time with us. And please remember to complete your post-webinar survey to once we wrap up. Okay, your feedback is really invaluable for us. Okay, and again, before we say goodnight, we look forward seeing all of you at our MSART 2024 in October. All right, thank you. Take care and have a wonderful night.
All right, thank you. Bye.